Gotta put my slides up.
Where if we,
She's
when
still
I
learning.
have
She
said
getting there.
all I can say and provided all the evidence that I can provide, but you still want to think
That's all right.
you
You're doing
know
good.
more, understand more, without any background knowledge. I have to let you just burn it down because I'm not.
All right. Well, welcome everybody. Good evening.
Good.
This is the Scotland County Health Department Board of Health meeting, and then today is August 19th. We welcome everybody for coming, and thank you all for joining us. We're going to get kicked off here with our invocation. Commissioner Neal.
Okay, why not? All right, if you'd join me, please. Heavenly Father, thank you for those gathered here. Thank you for the work that we do on behalf of our citizens of Scotland County. Guide our deliberations and grant us wisdom. Lead, guide, and direct us in your name. Amen.
Amen.
First thing on the agenda, we will have a new board member to welcome.
Okay.
Dr. Killam?
Kellum, yes.
Killam. Good deal.
Put your hand on the Bible. Okay. And just repeat after me. I, Dr. Laura Kellum,
I, Dr. Laura Kellum,
do solemnly swear
do solemnly swear
that I will support and maintain the Constitution and laws of the United States,
that I will support and maintain the Constitution and laws of the United States
Constitution and laws of North Carolina,
and the Constitution and laws of North Carolina,
not inconsistent therewith,
not inconsistent therewith,
and that I will faithfully discharge
and I will faithfully discharge
the duties of my office
the duties of my office
as a member of the Scotland County Board of Health.
as a member of the Scotland County Board of Health.
So help me God.
So help me God.
I, Dr. Laura Kellum,
I, Dr. Laura Kellum,
do further swear
do further swear
that I will well and truly execute
that I will well and truly execute
the duties of the office as a member of the Scotland County Board of Health,
the duties of the office as a member of the Scotland County Board of Health,
according to the best of my skills and ability,
according to the best of my skills and ability,
according to law,
according to law,
so help me God.
so help me God.
Just get you to sign right here. Sign this.
Yes, ma'am.
I left mine down there.
Small child, I was around. He tested positive. I don't know that I was around him that long, but just to be safe, I'm wearing a mask. Look like a bandit on me. Reminds me of what I had to wear one every day, all day.
All right, welcome aboard.
Thank you so much.
It's official now. Welcome.
Thank you.
I overheard you've been a member of the community for quite a while, and we thank you for electing to serve our community in this capacity.
I'm looking forward to it. Thank you.
You're welcome. Moving ahead here on the agenda, you all have the agenda in front of you, and it's the same that you received in your packets, I believe. Amanda, are there no alterations? Any discussion on the agenda in front of us tonight? Hearing none, I make the motion to accept tonight's agenda.
Second.
All in favor?
Aye.
Aye. Any opposed? And we're unanimous on that front. You all also received the meeting minutes from our regular session and closed session in your packets. Do we have any discussion on the open minutes? I take silence as good there.
I make a motion motion that we approve the, Board of Health open, and special meeting minutes from June 17th and July 23rd as written.
I'll second.
Ms. Diane seconds. All in favor?
Aye.
Aye.
And I heard everybody's voice, so we're unanimous there. All right, now we're going to move forward into the public forum. Do we have any members of the public that would like to speak tonight? All right, seeing none, we will move forward there. Now we're going to move into departmental updates. The first is Mr. Tim, the fiscal management section.
Good evening. Before you should have your report. It looks a little bit different this time than what it has in the past. I tried to simplify it a little bit, so it wasn't so many pages, so I tried to make it just a one-sheeter for the finance part. And then there's a few things after that that I would like to show you guys or explain some things. First sheet, of course, always 10 essentials, public health services. So we have I combined those two pages into one page. So basically, what you see on the first column is the expenses. What you see in the next column is the revenues. And in the next column will be the actual county allocation. This should be the second page in your packet. It's only been 1 month, so it's really not a whole lot exciting to talk about within 1 month of the year. I do want to draw your attention to where it says federal and state grants. Please note that we're always a month behind. We have to spend the money before we can recoup the money. So that's why the revenues are zero in the state grants and federal grants. Any questions? Is this a little bit simpler, simplified, or that's two less pages, right?
That's
Than
right.
what was there before? Okay.
Is there anything that, I know we're 1 month in, but is there anything tracking far ahead or behind what you would expect with 1 month?
The only thing that we normally have a increase or a thing at the first of the year is a lot of our software fees. Like, for example, environmental health, we pay $12,000, right? Something like that. Or for fees for using the state's environmental health software. So that comes out at the beginning of the year. That's why you'll see environmental health expenses, $5,100.
Yeah.
So, $28,000 because it's salaries plus we've paid for that software fee. But that software lasts throughout the whole year. Other than that, July, we were not able to spend a lot of money due to the fact that the county was turning over to a new year and due to the change in some things at the county finance office. So we were probably 2 or 3 weeks behind where we would normally be. So the month of July, we pretty much paid salaries and fringe, and that's pretty much it.
Great explanation, thank you. Any other questions for Tim before we flip on?
Just a note, we're interviewing for a finance director next Monday. So hopefully this,
Yes, sir.
if we find a great applicant who accepts our offer, hopefully we'll have the finance director role filled in the
Wonderful.
not too distant future.
Wonderful. I deal with the finance officer on a weekly basis. So now we're getting there. So it's just good. So the next page is, I had done something similar to this before. We have ended FY '25, so as of June of 2025, I did want to give you some numbers. These are the amount of money that we've collected for programs, and I did do an analysis for the past 3 years of where we were. FY '25 is in the blue, FY '24 is in the green, and FY '23 is in the purple. There are some areas this past year we've done better in than last year, and some areas that we've done a little bit worse in than last year. I'll give y'all a few minutes to look at that, so, and see if you have questions. And I apologize, that SC number is not right. So I do not know where that number came from.
Which one?
The STD number,
Okay.
I apologize, that's definitely not right.
Oh, okay.
So my fault on that one. STD number for FY '25.
Do you have an idea what it should have read?
It's probably about what it was in 2003. I'm thinking it's around $50,000 is where it should be. And apparently my thing didn't calculate right because immunizations is wrong as well. So I apologize. I guess I didn't overlook at my sheet.
So what should the immunizations be at?
Probably it was around 48 to 50,000.
So immunizations drop substantially from.
I'm going to say 48, 50,000. I'll just a guesstimate off the top of my head. It might be more. I did not bring that paper with me.
Okay, so immunizations is affected as well.
Yes, sir.
Okay, gotcha.
But
My-
I would also probably
my
say the
apologies.
difference in the drop could have been because of COVID vaccines. We did probably less in
Mm-hmm.
'25 than we did in '24.
Mm-hmm.
Yeah, I didn't know if that might have shown up in '23. But, okay, thanks.
Tim, can you revise this for the,
Yes, sir.
the meeting minutes
Yes,
that
sir.
we receive next meeting?
Once I get back to my chair over there, I'll probably find the number for you and I can update it right then. But
So the child health number was 0 in '23.
yeah, we did not have a child health program in
We
'23.
didn't have it. Is this the one that's from like the grant or that?
This is actually one that Joy actually operates as the postpartum home visits.
Yeah, that's what I was like. That's from a grant, right, that we got? Or is that?
It's just a program we started
Uh-huh.
that it's not necessarily a grant per se.
No, it's the child health allocations that we get from the addendum from the state.
Mm-hmm.
We brought Miss Joy on, and she had started up the postpartum home visit. She goes out, makes a home visit with the mom, the baby, checks the mom, checks the baby. We've kind of had to put that on hold right now because we don't have enough nurses for her to continue with her postpartum visits right now, because she's actually working the clinics that we have within the health department.
Okay.
Instead of 9 nurses, we have 4.
Okay. I'm sure we'll get to that later.
Okay, I can go and tell you what happened. The immunization number and the EIC HIV numbers backwards in blue. I can tell that's what happened.
Okay.
So
So-
the
So HIV should be 73.5. I mean.
the HIV should be the 39,182 and the immunization should be 74. I can see what happened there. But I will get it corrected for you guys.
Thank you, Tim.
So is that in question? Because I know that our HIV numbers went up like last year.
Correct.
So is that part of where the cost, where it went up? Because
We
provide
have
more
lost
services?
several HIV patients due to well, we were receiving Ryan White funding for those who did not have insurance, who have HIV when Medicaid expanded, a lot of those people that were running Ryan White funds were now eligible for expanded Medicaid. So therefore, we lost, actually, I think we're actually looking at closing our Ryan White program now at all because we only have 2 patients that qualify for that. So,
And we'll talk about that more when I do my
Yeah.
director's report.
so the HIV is going to the HIV EIC clinic's probably going to go down some since there's fewer people. Because if we can't see them and we don't have Ryan White funding, they'd have to pay for it themselves. And we would prefer them to a provider who could actually see them. instead of making them pay for their services. So.
Yeah.
Any other questions? So the next page, really quickly, I did want to boost our Labs to Go program and let you see over the past 3 years the money we brought in for that program. So if you see in FY25, we did have an increase in that program for revenues. It is a very good program. I think you all are aware of all the things that they do and that they're able to do. The lab prices are cheaper in our program than in a lot of other places, a lot cheaper than other places. And so as long as you have a doctor's order and we have the lab available, we can get that lab for you. Or if there are some few labs that we can do without a doctor's order. But please note that no insurance is filed, it's cash only.
And we have gotten a lot of response from actually county employees because of our high deductible insurance.
Yeah.
They choose to come in where we offer the labs cheaper
Yeah.
instead of having it done through their provider where it goes through like LabCorp. And we get a lot of county employees coming in for labs, through the Labs to Go, and they just pay out of pocket.
Do you know what things you cannot do? Right off the hand, one or two things that you can't.
I do not know right off, I just updated the website, so it's on the website. When you go on our website, to the Health Department's website, it is on there, Labs to Go, it says the following tests are available without doctor's orders.
Yeah.
It's probably 10 or 12 tests
Yeah.
that's available without doctor's order.
All the regular stuff is available.
Yes, sir. Yes, ma'am, sorry.
CBC, all that, everything is, okay, that sounds good.
And I think the list has grown to probably 40 or 50 labs we offer now through Labs to Go. So the number keeps getting big. If you need a lab and we don't have it, then we'll contact LabCorp and we'll find a way to get it for you and be able to help you out. So the second little chart there is environmental health revenues. This past year, 42,000 for revenues. Not sure what happened in 23 or not happened in 24, but 25 we did increase a little bit more than we did in 24. So, and please remember, everything is now back at the health department except for the wells and on-site. That is still currently at the inspection's office. But everything else, water samples, well samples, food permits, everything is back here at the health department. So, any questions? So the very last thing is I went back through my notes and I did recall that I did have a conversation with, and you all would like more information on our immunizations, our private immunizations that we offered. I think I remember someone asking that question. So the next page just shows you in FY25 all the immunizations that we gave privately. This does not include Medicaid patients. So I'm not going to say I know what all these vaccines are because I do not. I know what some of them are. Some of them have different names than this that were actually on here. But in the column beside is the amount of vaccines that were given, those vaccines given, and the next column is the amount that we collected for the year for giving those vaccines.
So when we do back-to-school immunizations, how does the financial part of that work?
Majority of the time when they come in for their back-to-school vaccines, they have Medicaid or they have private insurance. If they do not have any insurance at all, then it's free through the state's VCFC program, ain't that what it is? Yeah. But we can bill insurance if the child's parent has insurance, and that's where the private comes in.
So the registration process actually makes that determination whether or not you have private insurance
Correct.
covered by Medicare.
Someone calls to make an appointment for their child, said their child needs immunizations. The first thing registration will do before they show up will be to pull their immunization record to make sure they actually need the shot or make sure what shots they actually need before they get there. If they do not have an immunization record in the system, we let them know that they need to bring that with them when they come to their appointment, preferably before they come to their appointment, so we can make sure we have, because when the immunizations, and Joy can speak on this if I can't, some immunizations are cold or frozen and you have to set out in order for it to thaw out to give. So you have to have time to know which immunizations to pull and which ones to drop. Am I correct?
And we have to keep the,
State and private.
State and
separate.
private, state and
that was one
private
thing I was
separate.
gonna say,
Private
the
have to be kept
price per vaccine varies depending on whether you are state or private.
Yeah.
But that's not from us in the county, that's from, what the state and the vaccine
Yeah,
manufacturers.
the reimbursement
Yeah,
rate.
so they're different, that cost, but you have to keep them separate, and it is important to know before, because like certain vaccines like COVID have to be super cooled, and you have to take them out for a certain amount of time. They can only be out for a certain amount of time. They only come, that one vial has 6, so if I have 4 people booked for it, I now have to waste those 2, because I can't save it till tomorrow. You can't refreeze them, you can't put them back up.
I guess I'm really wondering about the situation where you're out in the community giving immunizations. Are people really showing up with immunization records? Are they showing up?
Well, North
with proof
Carolina
of-
is a state that is well above most other states on as far as keeping accurate immunization records. So the North Carolina Immunization Registry, so NCIR, is the registry for the entire state of North Carolina. Every doctor's office, every health department, everybody can log into this, whether you're a child or a grown-up.
So you don't need a parent to bring an immunization record.
We do if you are coming from out of state,
state.
and you
Right,
have
but
never
I'm just
been
saying,
seen.
if you're down.
But
in
if
town-
you're in North Carolina, with hopes that all practices everywhere are putting their shots in when they give them into NCIR,
Sure.
you would not have to if they're here in North Carolina. You could look them up at NCIR. Like I said, that's again the perfect world.
so if we're out in the community doing outreach,
We can look it up.
the person checking the person in would have access to NCIR.
So you use NC. I'm just thinking if somebody's out at a festival or something, they're probably not walking around with a paper immunization card
yeah,
in
you
their
can look 'em up.
pocket, nor an insurance card for that matter, a lot of times. So that's what I was kind of wondering is how do you navigate that? When you come in here, it's kind of expected. You're going to the doctor, bring your stuff. But when you're out somewhere else, it's not the same.
For example, Saturday, we were at back to school
Event.
NAACP event, and we did we got at least checked 3 people's records to see what they needed. So we were able to do that. We actually had a printer there if we needed to print, but no one asked for their record. So we have that available for that. And also, if they come in the door, or before they come in, we check our NC tracks, anything, else, see what type of insurance they have, if they have Medicaid or what they have private insurance. We're able to check that. So when they come in, before they come in, we know, they automatically know this person has Medicaid, this person has private insurance, so they know what to pull immunization-wise, vaccine-wise.
Out in the community, you can still pull up.
You can still
NC
pull those
tracks.
You can still pull up NC tracks.
Well, that's good. So when people ask me about it, I'll kind of repeat what you've said here.
And I will give an example. For example, when I came to the health department to work, you had to have shot records for this. My shot record was on a card,
Yes.
like an old card, like from 1970, whatever. But I was not in NCIR, so they had to take the card and,
Right,
then-
and
and
put
transfer
in
the
the
information into NCIR. So there's a lot of that happens too. Actually today we had 2 kids who came in from North Carolina. They had some shots in North Carolina NCIR, but they were from Ohio. All their other shots were in Ohio, so we had no record of them. So they would need to bring their Ohio record, so we would make sure they had got the right shots.
Thank you.
So just at the bottom, just let you know that there's COVID and administration codes. Not only can we bill for the actually vaccine, we can actually bill for the administration of the vaccine, which is the nurse's time to actually give the shot. So this is where that number I told you was wrong earlier. So for 2024, just for private immunizations, we bring in $667,100 and some dollars. So Our private immunizations does make us some money. And once again, that money offsets the cost to the county to provide services.
We still. And is it correct, we still not gonna have like the 6-month to 12-year-old COVID vaccines? Or are we gonna get them?
I am not aware of any COVID vaccine.
Okay.
And I would just draw your attention to the influenza flu shots. We did give 162 flu shots last year. So, here at the health department. Any questions? I will get those numbers updated for you guys and get them to you. If not before the end of this meeting, the next meeting for sure. All right, thank you so much.
Thank you, Tim.
Thank you.
Now we're going to ask Ms. Oxendine to come up and give the environmental health update.
Good evening. Since our last meeting that I was able to attend, we have permitted 2 establishments. That would be Stop and Go at 130 South Caledonia Road. It's a convenience store which has a little kitchen on the inside of it. And Kyla Mae's Kitchen at 1482 NC 71. That's in Maxton on the line. Okay. We've also permitted a mobile food unit that is able to operate anywhere in the state of North Carolina as long as they have an active permit, and that is Gelly's Churros and Snacks. Our animal control program is currently out of one animal control officer, who is Mr. Mark Brown. He is out on FMLA. Adam Laus is covering the entire county. The sheriff's department has stepped up to the plate and is able to kind of alternate weekends when Adam's not on call. So we're grateful that they're able to help us while Mark is out, and hopefully he'll be back with us soon. In case you get any calls, we are continuing to work with the animal shelter. We actually got a email this morning that they are still currently full. We have a list of dogs and cats that are needing to be taken in. So as they get space, that's how we're working off that list, is kind of checking things off and sending things in, okay? Another thing, and I think I kind of touched on this the last time that we had our meeting, is that we collaborated with Cooperative Extensions, and Ms. Sharon English, I'll have her to come up so I can introduce you to her. Ms. Sharon's a fine lady. We come up with the idea of hosting a food handlers class and kind of getting out to the community and kind of spreading the news of how to cook food and how to store food and how to do things safely. So I went to her with this idea, and she was like, yes, let's do it. So we collaborated with each other, and Miss Sharon teaches our Surf Safe classes, which is a requirement for our food establishments. They have to have Surf Safe and be a certified food protection manager. So we got together that class, and we kick-started it at New Hope. Is it Baptist Church?
New Hope Baptist.
Yep, and we had 14 at the time. And it kind of got out into the community, and I got a telephone call from her, and she says, we got another church that wants us to host the meeting. And I was like, well, good. Where is it going to be at? And she told me that it was at Brightwell.
Right, Hopewell.
Mm-hmm. And we hosted that class last week.
Yeah, I think it was last week, yeah.
Last week. And we had 62 individuals at that meeting.
Wow.
Yep. How many churches did you say?
21.
It reached 21 churches
21
altogether.
represented 62 people.
So we are excited about getting out in the community and kind of offering this classes free of charge. We are educating them on the processes that they need to be following in order to have their festivals, their plate sales, whatever they want to have, any big assembly that anybody wants to have. we're able to go out and teach that into our community, and we're excited about it.
We'll
Do you-
reach clubs and other organizations too. It's open. you know,
great.
That serves the public.
So anybody that comes in contact with you and they want this information, they can reach out to Ms. Sharon at Cooperative Extension's office here in Scotland County, or they can contact me at the Health Department and we'll get it all set up. Okay? And that's all the updates I have for you. Any questions?
That is absolutely fabulous. I think that's wonderful.
Thank you. Yeah, we're excited. It's
Trying to get
been really
education.
successful.
It has. Just trying to
Good
get the
job.
education out there.
Good
Yeah.
job. It's really needed. Good
Yep.
job.
Yep.
And I'm writing a special article about it.
That is great. That's really good. That's really good.
Yes.
Yeah.
Because you never know at churches, because we do some things at St. John, and you always, you want to be careful. And I've watched that whole process, and they do a really good job. But sometimes you just need some formal training and just listening. So I
Right.
think that's really good.
And we were having the conversation earlier because one of the big topics in our classes is chicken and how to prepare chicken. And when the conversation comes up is that, you're not supposed to wash your chicken, everybody goes into a fit and like, are you meaning to tell me that we don't have to wash our chicken? And we tell them, no, that's not safe practices.
Yeah.
But we're getting the education out there, and if you know anybody that wants that class, just feel free to contact us. And that's all I have.
Thank you.
Thank you.
Thank you.
Next on the agenda is the Health Director's report from Miss Amanda.
Alrighty. So I wanted to give a clinical update, since Donna is no longer with us. She retired on August 8th. So I wanted to kind of update you on some clinical stuff. Lisa Freeman, who's our nursing supervisor, is currently serving as the interim DON until we get someone hired. The Director of Nursing position is posted on the county website and will be posted until the 22nd. The other thing Tim mentioned about the Ryan White funding, we were subcontracting with Robinson County Health Department to serve HIV patients who didn't qualify for Medicaid or insurance. And we were receiving, Tim, I think was it $30,000 a year. But that contract, will terminate on September 1st because one of the stipulations with that is that we have a HIV case manager that when those patients are when they're seen in the clinic and they come in and they're having other issues like housing issues or issues getting medicines or whatever, that we have a HIV case manager available to assist with those things. And we had one that was being funded through the Communicable Disease Grant, which was part of the ARPA funds. It ended May 31st, and we asked the county to fund it for this fiscal year, but that was one of the things that was denied. So Robinson County is pulling the $30,000 funding out and has asked us to refer those patients to other clinics for services. We will continue at our HIV clinic, but we will only be seeing the ones with Medicaid and insurance. Any questions on that?
So if funds come back, then you could see
If we
the
could,
uninsured.
right, if we had the funding.
Do we know, are there additional grants and stuff that I guess the grant writer could apply for that could be a use
I have
for those?
actually looked myself and have not been able to find any.
Okay.
Most of them are connected in with counties that already have the Ryan White grants
Grants.
already. So I haven't.
So having the Ryan White grant is kind of a precursor for most of the other grants
Right.
that
that kind of
provide
go
HIV services.
to the uninsured.
Okay.
So help me understand, so Robinson County had the Ryan White grant.
They have the Ryan White grant, and they were subcontracting out with us
Okay.
to serve Scotland County patients.
So
that
when
didn't
did we
have-
not, did we not get the Ryan White, or when did we stop getting the Ryan White grant?
I've been here for 3 years, and we've always subcontracted out, so I don't know did Scotland County previously have it, Tim?
We looked at applying for the grant one time before with
Mhm.
the previous health director. However, we did not follow through with that, because some of the requirements that we couldn't meet, which is why, to begin with, we were with, a different, I think of somewhere in Cumberland County that had the Ryan White program. And then we went with Robinson County actually houses the program, but however, in order for them to get the grant, it has to be a nonprofit. So basically, I think it's called Dogwood is actually the name of the company that separate, but they don't just service our county, but they service other counties as well. So, but previously, we had another county that we dealt with. We looked at it one time before. Currently, our contract with Dogwood is good until this coming April, next April is when, not
September 1st, they
September
pulled.
1st? Okay, I'm sorry.
How many patients uninsured were
Only
you working?
three
Only
patients
three?
right now are being affected, because as Tim said, a lot of the patients that we had, were able to get Medicaid,
Okay.
through the Medicaid expansion. And so that only left us 3 patients that didn't have any kind of Medicaid or insurance currently.
And as Miss Amanda said, it's not just seeing them for their medical care.
Mhm.
It's giving them other referrals for eye care, different things that social workers would do for them that we no longer have a social worker for. So, and Donna, the DON at the time, took on a lot of those duties and getting referrals. So we asked Robinson County to help us with the referrals, and since we asked them to help with referrals, they decided, well, if you only have 2 patients or 3 patients who are on the services, then we can
Just
assist
refer
you.
me.
So help me understand, you mentioned that a caseworker would help somebody if they needed housing. Why couldn't one of our social workers help with that?
At the health department side?
Yeah.
'Cause they have pretty full caseloads already with the programs that they serve, and they're funded through the managed care insurance.
But does that mean they can't help?
No, they could help, but, I mean, they already have really huge caseloads. We actually did have a social worker at one time, that helped out temporarily. But then it puts them behind meeting their performance measures because there's only so many hours in a day, and the managed healthcare plans say, hey, you've got to see this amount of patients, and you've got to do this, this, and this to meet the performance measures. So it was pulling them away from their
So how many patients are we talking about? Do they show up on here?
3
3.
right now.
So
Because
you're,
as I said, we had more than that, but with Medicaid expansion, they are able to get Medicaid, and so we can continue to see them in the HIV clinic. So right now, it's only 3 that's being affected by the Ryan White funding.
So all the rest are still getting the care. So so of those that we know, let's say a couple of years, it was like 8 people, right? So yeah, it's more, yeah, but let's say it was 8. It's just those other 5 are still being treated in our clinic and through our services. It's just those 3, if they were uninsured, right now we're having to
I'm gonna give you the best
outsource.
estimate number I can right now. I would say 15.
15.
I mean, that's about how many.
I mean, I know the
actually in
numbers.
Program.
Yeah.
But only 3 of them
Okay.
were not. The rest of them we're seeing through their
And-
insurance.
Is the
that
referral
doesn't-
process streamlined? Do we have a clean direction to point them right now?
The people that were actually on that list, actually are the next appointment when they come in, they're supposed to speak with the provider. The provider's supposed to talk to them about, where to help them get care.
To give them options.
Yeah. I just want to make sure we
And you've
we
already
give them a
got those
clean
options
direction.
for 'em,
Yes,
right?
we do.
Okay, that's all. Okay. So it's not like you like fend for yourself. They going,
Yeah.
cool.
We're still seeing HIV patients and adding them to the rolls, adding to our to our clinic if they need to be seen. It's just that those without insurance, we are having.
And you asked, was it on the sheet where it says EIC? Commissioner O'Neill,
Yeah,
up at the top. That's how many was seen in July.
so that PA is 10? Is that the number you're talking about?
PA, yes,
So that's 10 visits or 10 patients?
10 patients.
So out of that 10, some number may need housing, and we don't know what that number is, right?
Any other questions on that? All right, accreditation update. So we have received our 90-day notice that our self-assessment is due in the dashboard by November 1st. That is evidence of the activities that are required for accreditation. We pull the evidence, we upload it into the dashboard, and then the dashboard will close on November 1st. Then they will schedule, we can still add additional evidence until the dashboard completely closes December 18th, but they prefer us to have it November 1st. But after it closes, then we won't be able to upload any additional evidence, and they will schedule our site visit. Now, when I sent this out, they said it would probably be prior to May, but I spoke with Jana, who had another commitment, so she couldn't be here today. She's our accreditation coordinator. She received something on Friday saying that they were gonna have it scheduled in January. So we probably will have our site visit in January. Any questions on
And the
that?
site visit is for our self-assessment.
No, they will review everything that we have in the dashboard. They may also contact board members to ask you guys questions as well.
And while we're on that note, I think everyone should have received, as a part of this, a survey on this board.
Oh, that was for,
Different.
that was something different. That
Something
was for
different.
the county audit.
Okay, something different.
That was the county audit. Now,
But while we're on that, make sure you do it.
Okay.
Staff will, my senior management staff are a part of the accreditation team because they pull the evidence for their individual departments. And we will be watching a webinar on Thursday. I think I had listed it in there, and Commissioner O'Neill asked, was that something that y'all needed to view? Y'all really don't. Y'all probably wouldn't quite understand what they were talking about unless you've been involved with the accreditation process. But they'll just tell us how to upload the stuff into the dashboard. And
Okay.
Financial update, I wanted to give a shout out to our WIC department. Every year we receive agreement addendums, which is our allocations from the state where we draw down our monies. The addendum have service deliveries that we have to provide along with in order to receive those allocated funds. In July, WIC's deliverables consisted of maintaining a caseload of WIC participation of 1,285 participants per month. After review by the state, the WIC department was identified as exceeding that benchmark by 101.89%. Therefore, the state has increased our caseload to 1,300 participants a month and also increased our funding from $257,414 to $260,107. So this is a great accomplishment for our WIC program that they have reached and exceeded that benchmark. The next thing is lead and asbestos. Lead and asbestos are well known to be hazardous to human health, and especially the health of children as their bodies are still developing. The State Department of Public Health receives some funds, and they have allocated it, to different counties. Scotland County has been allocated $11,455 for this program where our environmental health will go in and do inspections and help the schools and the daycares with that. And Miss Valentina will be going to the training for this new program in a couple of months, next month.
Next week.
Oh, is it next week? I know they kept changing the date, so.
How will those funds be spent? What does that really mean?
It would mostly probably be spent on what, supplies and,
So we can use that for anything that goes back into our program.
right,
And,
there's a list
that
of,
can cover childcares, and that can cover lead, and it can cover schools. Because that's a threefold to that program.
It's just not much money. If you have to remediate something, you couldn't.
Is it
touch
just to identify, just for the testing aspect?
Yeah, that's what kind of struck me.
I was gonna say, the lead testing is already done, like, by the state for 1 and 2 year olds.
Right.
So that's done at every, like, well visit. We already do it. And so we kind of have data, I guess, on, are the lead numbers for here
It's the same across North Carolina.
is equal, right? So they want us to identify, did they use this to say, like, they identified more buildings built before 1916 or places, like, did they identify that we had more risk for lead and asbestos
What
to give the
happened
fundings?
was that the state got funding through RTI, which is the Research Triangle Institute.
Uh-huh,
And it's for clean water for Carolina kids
yes,
and clean water for schools. So what they were finding is that you have some of the schools that are kind of old, they've got asbestos in it, they've got lead piping in it
Yes.
where the lead's leaching out into the water.
mhm,
So they've hired contractors to go into the child care facilities and schools to test for those things. And then as they find them, we are following up with a mitigation of it.
okay. So it's us to follow up after they've kind of already found it, contracted, and had somebody fix it, for us to go back and test and make sure that that lead is no longer present, the asbestos is no longer present.
And that's totally different than
From-
if we go into like a house, like if we have a child that has an elevated blood lead level,
Yeah,
or if we have a child that has a confirmed lead level, that's totally
that's a
different.
different,
This money doesn't go towards
towards that, right?
So
So
this
this
is
is-
verification testing, really. The work's been done. Now we want to
We're
know.
following up.
That's right.
Okay,
So this
Yeah.
money can go back into our program, it can go towards bonuses, it can go towards supplies that we need, anything that we need to be able to function as, those things come in. And luckily, we've not had anything tested positive yet.
okay.
okay, I wanted to talk about our outreach. These are the dates of some things that we have already committed to. April 5th, we did a lake clinic for family planning services, which kind of goes hand in hand with the Women's Health Grant since we are no longer with St. Andrews. We're providing that service at the health department until I can get a health educator, because the health educator left about the same time as St. Andrews closing. So that the health educator can get out here and coordinate with a different facility to do the family planning services. We participated with the diaper drive and parent education at Franklin AME Zion Church, providing immunizations. We participated with the back to school NAACP back to school. We're also providing back to school late clinics at the health department. Breastfeeding and parenting classes are still being offered, community resource fair at the church and community services, and upcoming late night family planning clinic, back to school clinic in September. I also wanted to include that the Board of Commissioners made a request of us to use our mobile unit to provide immunizations at the community center.
Not really.
Well, it came from the county manager. She sent me an
No,
email
no,
that
that's
y'all
not,
requested.
that's not what we asked. We asked about doing immunizations. We didn't say anything about the mobile unit. We just said, could immunizations be administered at our community centers? Whether you use the mobile unit or not is another decision, but we read over and over that transportation is the number one issue for access to care. And we're saying we have a network of community centers. Have we thought about leveraging those being in our communities for people to be able to go and
Well,
make
the
that
problem is
available?
not, doesn't come with using a mobile unit, because we can definitely use the mobile unit, or we could provide them there at the center. However, where the problem is coming in is that according to North Carolina statute, we're mandated to provide certain essential services at the health department. And currently, we're so short-staffed, instead of 9 nurses, we're down to 4. And so we don't, if we provide it at the community centers, we would have to close the clinic to take those nurses out of the clinic that are providing essential services and move them over to the community centers to provide it, the immunizations. So therefore, your
Yes.
family planning, your STDs, and all those essential services that the state mandates that we provide at the health department would, you know,
Well, how are we doing them at other locations then? Are we just doing them on Saturday and Sunday?
we are, and unfortunately, you know, we can't afford to pay our nurses any extra for the Saturdays and Sundays. I mean, we have a pot of money, but we haven't been able to use it for like an incentive for them to work on the weekend, and if they choose not to work on the weekend, it's not in their,
Well, I don't think we're suggesting that it be on the weekend. That's not part of it. The thing about it is there's an absence of initiative to go in the community
I
and
don't think
try
it,
to deliver.
I don't think that it's that, we're not taking the initiative to go into the community, because I, for one, ever since I have been here, and even when we got the mobile unit, that was my thing, you know, let's bring immunizations to you down the street. However, if you don't have the people to give the immunizations.
Okay, but I've been saying this for 8 months.
I've been saying it for 3 years.
So this is not like something I came up with yesterday. I've been saying we have community centers, we have small communities out there, and I see zero effort to say, not how can we not do it, but how could we do it?
I tell
Who
you, if
can
we
we-
could hire some nurses
Let
to
me-
do it,
But
Then
who
we
do
could
we
get it done.
partner with to make this possible? Right? How do we get this done? And I'm just saying, I think there should be some effort toward how can we instead of why we can't, right? So just if we flip it, I think we could find some solutions. I mean, we have EMS parked in Wagram. Why can't that be the second person in an immunization scenario? I'm just saying, I mean, I'm not,
So I'm gonna be honest with you, okay? Because I probably didn't. So I will personally say that being a resident, a product as a child, a caregiver in this community, I take probably a little bit offense with the saying we are not taking the initiative, because I can say that that is untrue when you know all the things that come into delivering health care to the community, right? It's not just as simple as taking a mobile van to a site and say, we're here, okay? And it's also not as simple as saying, we have a person who has some medical background, so why can't they just give the immunizations? That's not how it goes, because giving those immunizations is a very, very specific skill that even adult nurses will not do on peds patients. We have practices here that are adult providers that they don't see kids. They will see your child, but they will not give vaccines and send you to the health department because their nursing staff, though they are excellent, are not well trained and certified to give vaccines to children.
That's right.
So you can't say there's no effort. So when we say that we need a specific type of nurse or provider, it is because you have to have a specific set of skills. It's just like I can't just go and say, let me go treat this 69-year-old. I'm a doctor. So I can treat this 69-year-old. I can't because my training is in pediatrics.
Yeah.
So when we are, and I'll say that since I've been on this board for 3 years, my first thing when I came that first year, even as a doctor, I asked questions and listened before offering tons of suggestions because I needed to understand the foundation of public health as a whole. Because even though I am a doctor, public health is very different
It is.
than providing health care. And so it is not the same thing. So it's not apples to apples, oranges to oranges. Also, we have been trying, and you may not see how things have come better or gotten worse or from where they came from. Sometimes when you don't know that past, you can't appreciate what's in front of you. Okay? So when we came here, the same thing that you're being okay about, that these numbers seem okay, and okay, we got these HIV cases, and you weren't here when these numbers were even lower than this. And in 3 years, we got people to want to come back into the health department. So the reason was people didn't want to even come. So now we have people that are coming in. So now we have the ability to go out because we've rebuilt that trust with the community. And so now we are in a place where we can go out and we are trying to go out. And I will be honest, we as a board have actually come to them and offered more than enough suggestions on how to incentivize, on how to get the community out. And there are things that we as a board are unable to okay. And some things that we as a board, we can suggest, we do not have the final say. And I would be hoping that as our commissioner, you would really come to talk to us about what's been going on so that you could go back and understand where we're coming from. Where did we come from and why are we advocating? Because you may not know that these positions that we're talking about, do you know that we actually had tons of meetings with the county manager and with the health director? We've had them. And I, in my face, have been told we don't have the money, so they're just going to have to do more work. And so when you come and also ask them to take on additional court patient loads, even with HIV, Amanda's response is they already have a caseload because until you've worked a caseload of 50 WIC patients, it doesn't seem like a lot to you until you are the one doing the work. I may see 25 patients a day. For me, that is cakewalk easy money because I can see 25 a day now. But when I first came out as a graduate, I was struggling to see 18 a day and get my notes done because I wasn't there. And that's what we're hiring people, and we may hire them in, but they're not there yet to do it. And to get them there takes time. We have been trying to fill these positions because we knew this day, this moment right here was coming, and we were trying to hire them last year so that when we got here, they would be trained and ready to go out. But when you are told no a year ago, when you were trying to plan for what we knew was coming, now we're here and we have you and other commission people coming and saying, why you did, well, we actually were trying and fighting. And we were really, really, really working to try to fill positions, to try to get out in the community, to try to make things happen. And we were told no. So I'm not, so I want you to understand that I think that sometimes we need to have these conversations outside of here because there's a history and this isn't just history to say, well, we need to change the narrative, or because we coulda, woulda. No, it is because people who are completely and totally dedicated to this community and these people, that we do this for $45.
Tell me about it.
So, yeah, you get more because you're a commissioner. We get $45. Okay, so to sit and do and put in the background work, to go and meet with Amanda, and to go meet with April on my days off is a sacrifice. And so to know that I've given all that I've given to help and to see the numbers and to see the reaction of our citizens on Saturday at the back to school event, that they came to that table happy, laughing, and even 3 months ago when the health department came to the other community day pump out, giving out sunglasses. That is something you did not see here 5 years ago. You didn't. So I do say that we probably should be a little more educated and understanding of what we're saying before we say it, to understand truly where we're coming from. Because sometimes those words seem very simple. Like I said before, I do not like generalities. When you throw out generalities, then nothing is specific, and we do not know what that means. And that could mean tons of things to tons of people. When you are specific, then we can tangibly answer your question, and we can tangibly give you a goal and an outcome. I don't like when we say to be effective. Be effective in what? Being effective in delivering patient care, being effective in making sure our patients feel heard, being more effective in how we fiscally handle our monies. That's what I need to know, because being effective and efficient can mean very different things. Because effective and efficient to me as a provider is very different than effective and efficient to a chief medical officer or CEO or CFO. That's very different to each one of them. And that's what we have to know. So I'm going to say that let's not keep saying that we are not doing what we're supposed to, because we are. Okay?
So I'm going to articulate what I hear from people, what I see, and I'm going to continue to do that. This is not just I let you speak
I'm gonna let
totally
you speak.
uninterrupted.
Please go ahead, okay?
This is not just a child immunization issue. This is a broader issue, 12 months out of the year. Being out in the community is part of it. I mean, I can't read the community health needs assessment and see transportation and see these things in there and then act like it doesn't exist when it comes time to deliver services. So I think it is a fair challenge, and maybe a lack of initiative is a bit too strong. But I feel frustrated that when you say to people, get out in the community, it's like, oh, I'm just saying, I think it's important sometimes to ask ourselves, who can we partner with? I mean, there are I go to places and attend events where I've had my blood drawn for cholesterol. I've had all sorts of little things done that's part of a health screening process. People are out in the community and they're not the public health people. We are the public health people, right? I mean, that's part of their role, of course. I mean, even Scotland Healthcare System has a public health. But again, I would ask us to accept the challenge. And I know we as a county have to also accept the challenge of how do we fund this, right? What do we do to help make this possible? But I do think it's fair. And I think there's people we're not reaching because we're not out there. We talk about the stigma of coming in the health department. Getting out there is a great way to remove the stigma. And I'm not suggesting that we provide services that are unsafe or shouldn't be done in any other setting, but we have community centers. We want them to be utilized because people come there. We can engage them there. I hope that we can at least think about this going forward, and you start to see some events where We're at the Laurel Hill Center. We're at Wagram. We're at Scotland Place.
I will
If I could respond, please. That screen is telling us what the problem is. And I'd like to break it down. We're missing a director of nursing and 4 other nurses that are the kind of people that need to provide the service. So the way I want to break this down is, on the night of the Richmond game, when Scotland takes the field, if Coach Bailey takes 44% of the team, sends the other 66% of the team away, and says, okay, guys, go out there and beat Richmond, guess what's going to happen? When you're missing 66% of the team, you do as much as you can, and you have to start in the house. And I think people like Dr. Singletary, that's giving her time on Saturdays to do stuff when she's not part of the 44%. I mean, thank God we have volunteers that are providers that are willing to go try to make a dent in the need. But that screen right there says we're missing 66% of the team that is required and qualified and trained to do what you're asking. So you're turning to the other 44%, Ed, and saying, yeah, but y'all go out, y'all do all your job here, and let's go out there and do that too during the week. And Amanda's going to say, we can't meet the demand because the team, Richmond's got their whole team. Their whole 100% is out there, and we're trying to beat them with 44%. And that other team that I'm calling Richmond is the healthcare needs of Scotland County that needs them.
Well, I agree. I agree. Donna's been gone a month. Some of these other positions have not been vacant very long. I'm just saying, as we go forward, as we think about this, somewhere in our mind should be, how do we get to a state where that we can be out there?
We need a full team.
Okay,
And
so,
forget the
but
full team.
keep that in mind now, because I'm gonna hold you to that, because when we get a consolidated director, when we start making these changes that are coming in the future, it is our 100% commitment that we want those resources in place, but we have got to get out there as part of that wherever possible, because people need us out there. Our community health needs assessment has told us that. And I'm only saying, I read this, and it's not, I don't have to be a physician to understand transportation's an issue.
Sure. So I will say, all I want to, I'm gonna just, can I just say one thing? Because I want to just go ahead and finish this. So what I'm gonna say is that I hear what you're saying. So you're like, you want us to all make sure we're having in our mind that we're asking these other questions. I think for us, I can't speak for y'all, but I can speak for me. Okay. That statement for me is a problem because that actually is something that's been in my mind and been a thought and has been questions that I have verbally said out loud in meetings that if you go back and look at the videos, I'm pretty sure you could hear and see them, that I have had with Amanda, that I've had with April. So I guess for me, it's like you're saying that we aren't doing something that I personally know that I am doing and that I have been doing. And so I think for me, it's just, I want you to understand that sometimes those words are, maybe it's not that it's us because we have been. Maybe we need to look at the more fuller picture because there's always two sides to every story or outcome or whatever's going on. And sometimes we have to be privy and have both ears open to hear both sides. Okay?
Well, I can't see in anyone's mind.
No, I don't want you to see in my mind, but I'm telling you.
The only thing I can see is what we do.
I'm gonna let
And
you talk.
that's
If we could go back
that's
to the
my
previous
challenge.
page, can we do that? Is there a way to go? Yeah, go back to the first page. One more page. So, nope, go forward. Yeah, one more. Go back one. There you go. So we've been trying to get help, and then if you look in the second paragraph, actually, I think you asked about a case manager and wondered if we could get somebody from social services to meet this need. And I think it says up there that the HIV case managers funds ended May 31st, and the request to the county funding for this position was not approved by the county for fiscal year 26. So the thing you asked for, the commissioners said we didn't have the money for.
So
So
was
who's,
that your only option, was to wait till it expired and ask, or was there another?
Grants.
What about, but I mean, is that it? It just expires and then,
actually, the way I read this, Ed, is when they knew that it was gonna expire, they made the request, the county met and denied it. The
Yeah,
people that
so-
we need to help us are saying, just like Dr. Singletary is saying no to us.
yeah, well, I
And-
can
and
tell
then-
you, the
Like, it's-
commissioners didn't deny it.
Well,
We
it says the
didn't.
county
Well,
funding was not approved. Who does that, Ed?
It's not, okay, but I think you've heard it even from Dr. Singletary, met with the county manager and had this discussion. This was not ever an action item for the commissioners to go, no, we don't want that. So I just want to clear that up,
So
but
we can take it back and get that turned over and get the money then. Is that what you're telling us?
no, I'm not telling you that.
Okay.
I'm just telling you what actually happened, but
so, I'm a little confused. So, when department heads put in their capital requests prior to the budget being approved, do y'all not get to see that?
yeah, but
Because
we don't necessarily line by line it, right? Because we're looking at buckets of, so I don't think anyone looked at Ryan White and said, no, we don't want to do that. That's my point. I mean, I'm not trying to, shirk responsibility for it. I'm just saying we never acted on any specific request around this. So please don't walk away thinking that, because that's not the truth. But yeah,
Well, I think we probably do need to move forward, but as a nurse practitioner who has practiced in this county for many years and several other surrounding counties, I can tell you, and as being a registered nurse for over 25 years working at Scotland Memorial Hospital, I ran that intensive care unit over there for 25 years as an RN. And this right here, 2 public health nurse positions, 2 public health nurse 3 positions, a director of nursing. I can tell you, you cannot offer clinical services if you do not have the staff. That staff has to be licensed. I can tell you right now, as a nurse practitioner in this county, that you can't recruit advanced practice providers in Scotland County to save your life. We've been trying for over 3 years to get PAs and nurse practitioners in our clinic. You can't get them. You have to have the base. You got to have these people to provide that care. You can't just pull in John Henry off the street. You can't just do it. They have to
would
be. They
suggest
have to
that.
be licensed. You just can't. They have to be licensed.
And I will say, I looked into because I think you and I talked about LPNs for certain positions, and I looked into it, and a lot of our agreement addendums specify RN. So if we're gonna draw down the monies from the state on those particular programs, then it has to be a RN. I can't put a LPN in that slot, or else we won't be able to draw down the funding. Does that make sense? And the 2 public health nurse 1 positions, one of them's been vacant since May 3rd of '24, and 1 4/11 of '25. So, I mean, this is not just something that's happening now. The public health nurse 3 positions, one's been open since November of '24, and 1 has been frozen that we can't even hire for right now. We have recruited, we have posted, the positions have been on NeoGov and the county website for months, a year. We get people in to interview.
their salary expectations are off the chart. I've heard you tell this story. Yeah,
And even as basic as, I'll give you for an example, the last nurse that, we interviewed that I recommended to hire to county HR. There's when they post a position on the county website, you'll see a post, and this salary starts at, I'm gonna just use low numbers, $50 to $100. is the starting range for higher range. All right, if a nurse comes in and she's got, I don't know, 18 years of experience, you would think she wouldn't start on the $50 hiring range, she would start on the 100. No. If the HR department says, well, you know what? She had 18 years, but it was at the hospital, it wasn't public health, so we don't think that's directly related, we're gonna start her at the 50. So you call her up on the phone and say, hey, Miss Jones, would, you come to work with us for $50? No, I ain't coming to work with you for $50, I got 18 years in. And so what happens? We wait on the next batch of applications. And my 4 nurses, and Miss Joy's one of them, bless her heart, they're pulling more than their load. You know, when you got 9 and then all of a sudden you have 4 trying to meet all the deliverables so that you can pull down that money, because if you don't meet the deliverable, you can't pull down the funding.
I think I'm in my 3rd term.
We need to really look at those salaries. And then when they see different people say, well, you know what, they're not taking the initiative when they're really working their tail off, I'm sure that's hurtful. And I will say,
Let's-
one of those 4.
Okay, what I was talking about was the initiative around getting out in the community, not about the initiative
And
on
we get out
day-to-day.
into the community. You may not see it, but we'll get out. I can have Miss Kathy, my health educator, tell you, we're in the community.
We're in the community every Saturday and a lot of evenings
Yeah.
after work. Health educators are out there, that's what we're doing.
It's-
Now, we're not
it's-
earning money for the company.
No,
for the
it's not a
company.
blanket statement about being out there in that way. I'm just,
And I know you said something about drawing blood for
the
cholesterol
im-
and stuff.
the
We don't
immunization
have-
thing and just being
Public
available
health is a
to.
little bit different, well, really a lot different than the hospital, because if we go out there as public health and we draw your blood, okay? Say, or we check your blood pressure. We check your blood pressure and it's high. Legally, we have to have someone that's gonna take care of you now that your blood pressure's high. And if you don't have that physician there at the health department that's gonna follow you for care, then it brings a liability to the county.
It does.
Because if you go down the street after I check your blood pressure and I let you leave and your blood pressure is off the roof, liability, and you fall dead of a stroke or something, it's a liability to the county. So there's a lot of difference between hospital care and public health.
There is.
And the hospital has different sets of people that can go out and provide all those screenings, whereas we don't have different sets and a whole new crew that can be at 3 different events in one day. There's just a handful of us, and we are split thin going to events. Like this coming Saturday, there's a morning event and an afternoon event, and we're splitting ourselves. And there's only so much we can do, and we're always promoting public health and trying to get them to come here and participate in our programs and services, begging them to come and have their immunizations here. We do everything that we can.
And being
I've
fully
been doing this for
transparent,
24 years.
one of those 4 nurses had a job offer today, so I'm waiting till in the morning. She may be putting her resignation in, and we're gonna be down to 3 nurses.
All right, well, thank you all for this conversation. We'll go ahead and move ahead in the agenda.
Okay, the next thing was the Board of Health members. I wanted to give y'all an update. I know the commissioners were, looking at, you know, the vacancies we have, and they're trying to come up with their consolidated board or whatever they're calling. So, currently, we have the optometrist vacant, we have a registered nurse position, pharmacist, and public health member. And the dates out beside it is when the ones that are filled, like Dr. Singletary, your term would end in 26, so if you wanted to continue on the board, you would have to do another application, so. So we got 4 vacancies on this board. We already beat that dead horse.
If depending on what is easier for you to find, I can slide into the nurse position, because I sit in a public position. It depends on what you can find to take a place. I can slide around.
Thank you. I was gonna propose that.
Yeah.
It kinda, you
can
could
slide
float
from
you.
one to another, depending
Yeah.
on what you can get to, yeah.
Thank you. All right, we're gonna move ahead to,
So like many of you, I attended the Zoom call for consolidation, where they had Onslow, Guilford, and Forsyth County participate and talk about consolidation. And I think it's probably the best Zoom call I've ever been on in terms of substance and value. So Forsyth consolidated in 2018, Onslow 2013, Guilford in 2014. And in many ways, they were still talking about the challenges of consolidation. So for me, a big takeaway in that was that it takes a lot of time. It's going to be a slow process, and it's going to be a work in progress. We are going to be taking up the issue of governing board at our next commissioner meeting, and we're going to be looking at 7 consolidated health departments and their board structure, and we're going to try to take the best from that so that we get the right size board that can make good decisions from a size point of view, but also have the right representation. Our understanding right now is that maybe 3 to 4 members would be from the social services area, and then the statutory members would also be present. The consolidation provided a single vision and better integration of services. I think that was particularly important, and I thought that was a great theme. No wrong door approach, warm handoffs. I think those are things we certainly want, so that when people walk into this consolidated health and human services and they say, I'm here for WIC, there's some process that also says, how else might we help you? Here are our other programs that you may be eligible for, so that we can give you a holistic set of services that you may be eligible for, and provide that. And I think ideally be able to provide it in a coordinated visit, so you don't have to come back 4 times to see 4 different people. Perhaps we could actually intentionally try to schedule things so that a person can get more. So when they've taken the trouble to come down from the northern part of the county or something, they can get as much done as humanly possible. The advisory board meets quarterly. That's a part that we think maybe it might be as an every other month thing, more like the health board does instead of quarterly. Quarterly might be a bit too much.
do you know how often the social service board meets by chance? I know you're not on it, but.
Yeah, I think it does meet with that kind of the same regularity. My concern would be is when we get into consolidation, you have a board of commissioners that are really going to be trying to find their way around. And I think they're going to want a lot of guidance from the advisory board. So you're looking at it first would be a huge help. So I think probably every other month. One of the things I heard was that they really want to get feedback from clients to know, how is this working for you? A lot of times people built it, but really never asked the customer, is this working for you? They just focus so much on doing the work. So I think one thing we're going to try to do is from the very beginning say, hey, how well are we doing? Are we kind of, how was this for you? How was the experience of this consolidated health and human services? Make employees feel a part of it. I thought that was one of the best things I heard. In the process redesign for integration, really asking employees and clients together, how's this working for you? Is there a better way we could do this, right? Like if you're coming in for a child or a maternal wellness kind of thing, are morning appointments better, right? Or afternoons better, or, kind of getting that feedback, engaging delivery. We think the advisory board size somewhere between 14 and 18. Probably like to stay closer to 14 if, depending on what that looks like in the end. But I thought it was a great meeting, and I think we gained some good insight, and I look forward to talking about this in the future and seeing how do we make this as beneficial as humanly possible. I think we're going to review a lot of board minutes to see how those boards function, what kind of things they sought for approval, what kind of rhythm they were in, like on these meetings, do you take these actions, kind of thing. So we kind of know what the deliverables are, because I think even though the commissioners are going to do the training that's required to be on the health board, that's not going to be enough to help them sort of understand a lot of this. So we're going to be, I think we're really going to be leaning on the advisory board quite a bit.
So, question. So, because, well, I guess it was me, you, Bear, and Ian that was on the webinar. So, a couple of questions. These are like specific for us from being on the call that I had, from taking like the takeaways from hearing from the three, presenters, because all the information was very helpful and insightful. Yes, one of the things was they wanted to make sure that, all of their feedback from them was that they would, wish they would have had or taken more feedback, from their employees and from the clients to help better understand what is the true type of integration they needed to see. Because right now, a lot of them still say they don't have true integration. It's just kind of a
Work in progress.
a work in progress, and that a lot of them actually don't even have the model that we have here, where our health department and social services are in the same building. Because I think like two of them, their biggest thing now is they're trying to make sure they can put both services in close proximity to each other, because that was part of the problem, because they're not near each other. Where for us, that is already our basis, because we're already,
That's an advantage.
that's an advantage that we have from
Absolutely.
a lot of the other people, because we're already in the same building, which means we're basically more integrated than the people that integrated for consolidation, right? So then for me, it makes me think, are we doing our integration? Because one of the questions somebody had said was like, knowing that your reason for your consolidation, right? And for me, that's really for me is what I'm trying to get clear in my head is, so is our purpose for the consolidation to like streamline like the HR? Because that's what, one of the counties really said like that was really like their main focus when they started, but then they saw the other advantages. So is ours more like streamlining for HR and like organizational structure for the county, or is it that we're consolidating to truly integrate all of the services? Because I'm like, for me, I'm kind of like, because if it's to truly integrate the services, we kind of are already 3 steps ahead of everyone else. And so truly integrating those services would look very different for us. It may not, for me, it's like, well, it may not even have to be a true like consolidation of the boards. It's truly a like that means that, okay, that's why you would do the HR restructure. So it's not really like the board would change. So then my question goes to, if it's not for that, then when we're with this board, when we make the consolidated board, is it a board that, because you say advisory, but some say they're advisory, but they have voting rights, and some are advisory and they're just kind of like, here's a recommendation, right? So I don't know which model are we going for, because then now taking in what you said, it's like the commissioners are not going to be quite at that level, understanding everything they're going to be having to vote on, right? Is it more that this consolidated board needs to still have voting rights? Because if not, then that means that we're gonna be putting all of that on the commissioners to know and understand all of that if they're gonna be the final voting.
So I think to answer your question, I think our real objective is the integration of service for the benefit of the client slash patient. That's our number one driver, is how do we make this one-stop shopping and really integrated health and human services? Because let's face it, a lot of the same people are receiving services from both sides. But right now, it's sort of like we have two different organizations, and the integration piece, it's there, but it's not seamless. And I think that's what people are really kind of dreaming about, is getting to that seamless integration. Now, physical proximity makes that a lot easier, because if I make an appointment for this person and the 3 people she needs to see are along this hallway, then it makes it obviously easy to do that, right? Instead of having to get in your car and drive somewhere else or find transportation somewhere else. The second part of it is, I think this advisory board will make a recommendation. How you come up with that recommendation, whether it's through a vote or however, but like the immunization schedule, right? The fee for service. The way I would see it is the advisory board review it, ask the tough questions, recommend approval if that's something that has to be recommended or approved at the next level. It's not about it's really trying to let the advisory board inform the decisions of the people who have to make the fiduciary call, right, about it.
Okay, so basically, they would just be making recommendations for the commissioners to approve in their minutes. So it'd kind of be an extra line item in the commissioner meetings now for DHHS updates and services, so those things.
These are the things we need actioned, and that's why I mentioned we need to
But,
read their minutes and see how they have elevated issues, what kind of things were taken care of organically at that level, and then what kind of things were like, we have to take this to the commissioners. Because I can tell you, if someone adds a position in the county, that has to come to the commissioners. But we get it with a recommendation and background information that tells us, okay, let's do it, or let's not do it.
Okay, so then my follow-up question, because of what you said, that's why I jotted it down real quick. So as the commissioners are working on forming this consolidated board, you know, we're doing it like for integration of services, right? And to meet our clients' needs. Are the commissioners gathering input and, like insights from actual clients that are getting services now? Like that are coming through, like, maybe getting a survey so you can get the information from them about how to make it, and if not from clients, are they gathering information from, I guess, people who may have like specific knowledge in those areas, because if you're not getting information from someone who has knowledge of public health, but you're like developing a department without someone who has public health knowledge, it would be difficult to know, like, because in social services, when I'm dealing with CPS, right, it's sometimes a different outlook than when I'm dealing with my child who, may have meningitis or is undervaccinated. They're different things. Or if I'm dealing with a mom with WIC, that's different than CPS. And so are the commissioners getting that input from both sides, both someone who has a strong social services background and someone who has a strong public health background, in helping decide how this consolidation would work and for going forward? Because we know it's not just a one time we're consolidated and it's going to work. It's an ongoing thing. So having that ongoing input.
So,
or is it just the commissioners meeting and saying,
no,
this
as
is
a
what we're
matter of
deciding?
fact, every time we do something, we try to ask ourselves, what are other people across the state doing? So if there's 13 of these consolidated health and human services groups, obviously now, we're all not talking about the new director of health and human services. This person is gonna have a big role.
No, I'm not talking about that. What-
There will be a director, a
Yes, we
position.
know, yes. So we know we've already made that one, right?
So that person, though, is gonna have a huge role in informing both the board and the advisory group and being this
The glue.
The
person
conduit.
in the process, right?
Uh-huh.
So if you go out and you benchmark 13 other consolidated counties, it's not gonna be like commissioners sitting around going, how would we draw this if it was up to us? We don't have to do that. We can be informed by what 13 other counties have done and take the best and rely on the advice of the consolidated director and the feedback that he or she may get from their team, the employees, the patients. So it's not quite that commissioners are just gonna kind of freewheel this, because this is really the reason the director of the consolidated activity is really there.
So, okay, so that, no, so I think, yeah, so I get that, but I think for me, my question then is, well, then that follows a follow-up question, right? Yes, we know, so the director that we are currently, that's posted, that we're hiring for, right? That's the person that's the conduit, that's supposed to be the person that's gonna have both social services and public health background and input, and be kind of an advisor to the commissioners for the consolidated board and all those things, right? I guess my question is more not even like the long term. I guess my question is because I have questions about like this, how it, like making it go forward, because now I'm thinking in my head that so if this person that we haven't even hired yet is supposed to be providing the input on how we're going to make this consolidated board and how consolidation is going to look, how are we going to have that done by November the 1st? Or are we going to move this November the 1st date? Is that still an option? Because that because now in my head, I'm thinking, okay, we got to figure out, us, and like, if we don't know how many people are on the board.
I think things like that, I think we'll know before November 1st, right? We'll kind of pick an advisory board structure and see what makes sense there. But remember, I started this whole briefing about consolidation with saying that this county consolidated in 2013, this one in 2018. We're in 2025 and they're still not there, let's say. So
Yeah.
I think this is one of those that we're gonna put in the advisory board. We're gonna get this director hired, and we're gonna do the benchmarking. We're gonna figure out, engage with staff, engage with the community, and really figure out, how do we integrate health and human services in a way that really benefits our patients and our community. I don't think we'll have like a blueprint in January, because if you look at these if you were on the call, these people are still like massaging some areas, right? That they're saying, hey, there's still some rubs over here that we're trying to figure out.
So after the call, Ian and Dr. Singletary and I debriefed with each other, and three things that we came to similar agreements on that we wanted to share with you as our representative on the commissioners in this planning process, because as you alluded to a few minutes ago, y'all rely on us as a resource. So I really like what you said about meeting every other month, because that's what we wanted to suggest to you to take to the Board of Commissioners. So we're already on the same page with that. The other thing is the size of the board, and in our discussions, we looked at 14 and 18, but in order to make these two groups become seamless, there needs to be equal representation. So if you have a board of 18, because we have to be 9, then DSS is not going to feel outnumbered in their meetings, and the potential for a more seamless even though it sounds like a big group. Well, we're putting two big groups together, and we wanted you all to consider an 18-member advisory board coming from this consolidation, primarily
That's fair.
because we're looking at unity. And, you know, if you have 9 of us and 3 of them, they're not even going to want to come to the board meetings.
Yeah, see, that's, again, this is where I'd like to read the minutes, read the issues they're dealing with, look at their members and see if they did 9 and 9, 9 and 6, or, but I think that's a fair challenge. And I guess the other thing I'd say in response is that we can massage this as we go. So if we realize 18 is not enough, or 15 would be better, there's nothing to say we can't adjust after we do some learning, right?
Right.
So I think
And I
that's
think
fair.
what I heard in your initial statement that I really feel good about is the need for the county commissioners to rely on the board as a source of information to enable them to make the fiduciary decisions that they're empowered to do. I mean, you know, we just want to make sure that our voice isn't lost.
Yeah. And I
Because you have a
promise
team
you-
of experts here.
Yeah, I promise you, I don't think anybody wants to become sort of a, you know, I stayed in a Holiday Inn Express last night, now I'm an expert. I don't think anybody wants to do that. I think it's just figuring out what's really the purview of the commissioners, and that's what we should deal with. And what's the purview of the advisory board, and how do we make that work? So, because the consolidated director is going to be relying on both of those inputs, right?
Could I just ask one question? Because just going back to when all this first started, what is the biggest advantage of combining, of the integration of these two boards or these two agencies? What is the biggest advantage? You say kind of streamlining services to get them together, like if you're here for one visit, but I suspect that happens to some degree right now. So what is the biggest advantage of putting the social services department and the health department together as one consolidated unit? What is the biggest advantage to the county for that? Or a better question is, what is the biggest advantage to the consumer, the person who's getting these services? What's the biggest advantage to them to come to both these agencies? What's the biggest advantage for the consolidation?
To me, for me personally,
Uh-huh.
and what I have vocalized is, to me, it's all about the people who receive the services that we provide
Yeah.
across this spectrum.
Yeah.
And doing that in a seamless way, and not just treating people as if, okay, you're here for this, I'll take care of you. Now you're going to come back for another appointment to do this, but actually treating them holistically. So
Yeah.
when you walk in and you're getting here for child support services, and then someone says, well, hey, you know, you're also potentially eligible for this. And making this appointment system and everything else flow across.
But does that not happen now?
It
If
is.
someone said, it happens now, doesn't it? Because
Yeah,
if you're here and you're getting your child immunized and you realize there might be some deficiencies at home with maybe knowledge about childcare, or you've got a nursing mother, you go ahead and get them to the other agency. So I guess I don't really understand why the whole thing's going on. It doesn't really make a lot of sense. And it's not to say you can save money because you're adding a whole nother position. So what is the
I think
biggest
the main
advantage?
purpose,
Intention
Ms.
is not-
Diane,
This is not a money-saving
But I mean,
exercise.
from my understanding, the main purpose is to make sure there's an organizational chart that will support that seamlessness. Because right now, there's a director over each.
Yeah.
And if you had a center over that organizational chart, it would be someone that was fully involved on both sides. I know that Amanda communicates very well now across that hallway. But if you had one primary person to really manage that seamless transaction, I know, not to say that it discredit what happens now, but I think the commissioners see there could be a potential advantage of the org chart. Is that
Yeah, and I'll
it's
tell
more
you, these
organization
13
structure.
others that have done it
It's
have not done it with any bad intention. They've done it because they believe essentially this improves the service to the person that we're trying to serve. And I think that's where we're at. And I think it's the right reason. We're not trying to eliminate positions. We're not trying to save money. I mean, if we can save money by being smarter and allocate our resources differently, absolutely, anybody would do that. But nobody's here going, oh boy, we can save 20%. I've not heard that discussion with anybody.
So it's still, it's more really like a organizational kind of HR restructure to help to, I guess, define the integration of services that kind of is already going on. And then as that organizational structure is defined, then we can fine tune and refine how we're already doing some of these integration of services. Is
I think
probably a better
That's what we
way
heard a
of
lot
saying.
on the call the other night was people talking about work process and how work process has changed to accommodate integration.
Yes,
People
so
started thinking about
better way
what else and how do I connect? So I do believe that's,
I would say, I'm just, me knowing, not knowing, but just kind of with the way you word it can make a big difference on how people perceive what that change is. Being on the call helped me to kind of get organized and get a better understanding and a true understanding of what that word consolidation means, because sometimes it has a negative connotation when people are thinking about it. So defining, again, for me, this is by not using generalities, by being very specific in kind of what I'm saying, helps people to understand and go with you better. And so for me, in my understanding of what I've got from you tonight, from the call that we were on, is that in Laurinburg, our specific thing is not, even though we look at the other ones for how to do it, but our reasoning is not always the same for what every other county's reasoning was. And our reasoning, from what I can perceive, is that it was that we are trying to make a different HR organizational structure that helps or better defines the services that we're already giving and providing. But as that overall structure becomes more refined and detailed, it will also allow us to be more streamlined and integrated in our services that we provide already at our health department and social services. So we're not saying that jobs are not being done. We are saying that we're reorganizing the organizational structure to make it easier to flow money and decisions to provide the integrated services that we're giving here.
one of the things you heard the other night was that people were helping design the work processes.
Yes.
Remember, they said, hey, it's really good if people who do the work get a say in how the work is
And
delivered.
that's what I was asking.
Well, there's going to be a huge amount of that because when you make your focus, how do we provide seamless integrated delivery across DSS and health department, work processes would change, right? Because there's so many touch points with people potentially. Some people may get touched 15 times. Some people may get touched 6. It just depends on where they're at and what they need. So the workflow is really going to be the biggest change, is how do we deliver what we do today, but in a way that works. One final example. There's a book I read, and you guys have probably read it too. A woman has a suspicious lump. So they said in the existing process, somebody finds a lump and they say, okay, we'll get you back in a couple of weeks to do imagery. And then someone says, well, I'll read that imagery in a few days, and then I'll call you back and set up an appointment, and we'll tell you what the image said, and then you'll meet with an oncologist, and that oncologist then will develop a treatment plan and tell you what it is. This hospital president said, that's not good enough. They created a process where they said if a woman finds a lump today, by the end of the day, she will know what it is. And they took the same resources and they reimagined the process. So now they said, suspicious lump, let's get her into imagery stat. Let's get somebody to read that stat. If it's suspicious, let's get an oncologist stat, because they did it all for the woman. That was the only reason. The previous process was built entirely on what's convenient for the system, right? I need your records. I need you to call 72 hours in advance. All the rules that had been set up. But this one person said, we can do this differently. And that's the kind of thing, and I'm not pretending we can do everything that a person would need in both these departments in one day, but I am saying the power of that kind of thinking is transformational, right? And I think when we cut people loose and we start thinking about how work processes can change, I think it will make a difference. Now, obviously, we need people too, right?
Mhm.
You can't do all this without people. So that falls on the leadership to get those people, right? And
That was I was gonna say, we gotta have staff to make.
we
change
gotta
the
have staff,
workflows.
right?
Mhm.
And we gotta have patience.
Well, and was that story that was written in that book, was that about a hospital?
Yeah,
So it wasn't about a public health mandated arena,
no,
which, okay,
it was a story about the power of thinking differently, right?
right. Yeah,
So all
well,
I'm saying is that
I know.
the scale of our thinking differently won't be that, right? But it can be something else. And I don't know, if that doesn't get you excited, if the idea of doing this better for the people we serve, that should be just an amazing focus. But anyway, there was a third thing you had, Bear. I got 18 and every other month, but I missed the third thing.
I think it was advisory.
Huh?
What you wanted, the advisory part, I think.
I think we already clarified that the importance of the advisory board as a resource for the commissioners,
Okay.
that we don't lose our voice.
Gotcha. Okay, I got all three, and I'll bring it up when we talk about it. And as a matter of fact, I'll solicit the same feedback from the DSS board and ask, what do you guys and gals think we need from your perspective? They're only a 5-person board today, I think, so their perspective may be a little different. I don't know.
Well, one question you could ask them, how would they feel about a 14-member board where they have their 5 people, we have our 9, and that would be 14 members.
Just thinking out loud, I could see a scenario where you're making a DSS-centric decision, and you might say to those 5 members, you have the most sway in this, because it's really kind of technical on the child support, or on the DSS side, and then you may likewise say, for health board kind of issues, these 9 people will have more of a say. I don't know. I mean, I'm just thinking out loud. There might be some other models. And again, I think once we read the minutes of these advisory boards, we can kind of see how they parse that out. And we can interview them by phone as well and find out. But our first step is to kind of get started on this.
Well, thank you. Thank you for that, Nate.
Yeah.
That was thorough. I appreciate the conversation around it. Moving ahead here to new business. There's annual review and approval of the policy on policy that was in your packets.
According to accreditation standards, we have to review the policies every year. the policy on policy, my senior management team, we did not make any changes this year, but it has to be reviewed. So that's what was in the packet.
Are there any comments or questions on this? I'm gonna give us all a minute to flip through, but are there any questions anybody had? All right, I wanna take a few seconds here and let everybody flip if you didn't have a chance.
It's just funny, it's a policy on policy.
It's like the committee of committees. on
Yes,
committees.
this the committee of the committees.
Waiting to see some eyeballs.
Yeah. This did not staple.
All right, any comments for discussion? I believe this has been the policy on policy for the last 3 years. There hadn't been any edits. Any comments? All right, I'll make the motion here to approve let me make sure I read this right off the agenda, the annual review. And this, we're making a recommendation of approval of this policy on policies.
Second.
We have a second. All in favor, make it known by saying aye.
Aye.
Heard everybody's voices. That passes. All right, the next one we already heard about, but it's the responsibility of the board to approve the new funding that we heard about from Ms. Oxidine of $11,455 addressing the lead and water and lead-based paint in schools and daycares. That is to accept the funding from the state.
I make a motion that we approve the new funding in the amount of $11,455 for addressing lead in water and lead-based paint in schools and daycares.
I'll second.
All right, all in favor, make it known by saying aye.
Aye.
And I heard everybody's voices that approves unanimously. Do you have anything for me to sign on that one? Okay. The next is the approval of the new lab services for fiscal year '26, and that's the fee schedule.
Tim?
If I may say, the prices are not on there, but I can tell you what the prices are. Number one, is $299.
It's in the thing.
The second is $399. Number three is $85, and number four is $93. I apologize. there's
No,
an
we got it.
It's in here.
Yeah, you sent a
Not
memo.
on the agenda, but it's in the
You
packet.
sent it in our packets.
All right, I'm sorry.
So Tim, are these new or are they just ones that were left off?
These are new tests, that the two cystic fibrosis tests are something new that Maternal Health is now doing, where the state's asking us to do maternity patients now. As well as their partners, if they are positive, then the partners are being tested as well. The vitamin C and the vitamin E are additional labs to go tests.
Okay.
All right,
Motion to approve?
Second.
we have a motion to approve in a second. All in favor, make it known by saying aye.
Aye.
And that unanimously gets approved.
Those two sounded expensive.
They do.
All right, well, that is all that we have tonight on the planned agenda. Was there any final comments from the board before we adjourn?
I just
Thank
on the veterinary front, there's been a little bit of news in the last couple of weeks on zoonotic disease. So there's been an uptick in rabies. There actually was a couple of cases in Moore County, if you guys have looked at that. And then in South Carolina, there have been several horses that have contracted eastern encephalitis with all the mosquitoes, which is zoonotic as well. So, just to give you a little update on that.
Thank you for joining our board.
Oh, you're welcome.
Thank
You're
you.
welcome.
Hey,
Yeah.
in response to our health educator's story about this gentleman who was suicidal, I reached out to Danny Britt's office about why can't we do something about the presence or the fact that this drug is sold, I guess I can call it a drug, Kratom 7,
Kratom.
and creates these opioid type
Type
effects
effects.
and has all these severe things, and it's sold at a smoke shop of all things. And Danny Britt said it was, a bill was created in the Senate but did not get through the House. And then there's a House bill that's dealing with it, but I can't help but wonder, is this the kind of thing the health board could take a stance on to say, should this be in our community? And we have a smoke shop right across from Scotland High School. I mean, is that, and if young people are in buying vapes or, it seems like the access to this kind of stuff could be really bad. So
Can you repeat the name of that?
Kratom.
it's called 7, it's got a
Kratom.
long technical name.
Kratom.
Crap.
Kratom.
Kratom.
It's Kratom 7, but it's got another,
Um,
a name I can't pronounce. You have to go to medical school to be able to do that. But anyway, it
Pharmacy
makes me wonder, has the health board ever taken a stand on something like this to say, we don't need this in our community? It's potentially a danger to our residents. Do we have you guys ever seen any authority exerted or recommendation or?
So from what I know, so even as a board of health, we can say something, right? You can make a recommendation, but it,
But would we be
Doesn't
making
really-
a recommendation to the
Yes.
county commissioners to then elevate it above them?
so you
Or
could make
does
a
it
rec,
go through the
so
health hierarchy?
Yeah.
it would be more of, the state would have to do that because it would have to be kind of part of their checkoff list of what would not be required when Valentina does her approvals for occupancy and what you can sell. So it has to come from the state dictates what they can sell in the smoke shops. So we could say, hey, we don't think that smoke shop should be across the street from the high school. So we can control the locations in which they can open, but the Board of Health doesn't do that. That would still be
Yeah, that would be
zoning.
zoning
Yeah, that
for
would still be
us.
zoning for
But-
you guys. And so it's kind of more like we could make a recommendation that, hey, smoke shops shouldn't be within 50, feet or whatever
A
of
mile.
a school or a mile or wherever of
Or a
like
site.
a public school or something. And that could be a recommendation that then zoning can use to then say, well, we can't approve you for this space here, right? So then they couldn't be approved to purchase land in that area. But we would not be able to tell them they couldn't sell it.
Right.
Yeah.
But Amanda, what's the process for us raising the alarm through your network of public health to say, look, this is a public health thing, and I'm sure we're not the only county that is encountering this.
Right. Well, the health Health Directors Association of North
Yeah,
Carolina
yeah,
meets
yeah,
once a month.
around for
Like, I'll be traveling to Raleigh in the morning, Wednesday and Thursday. And we bring it to our work groups when there's an issue in the different counties. And we come together as a group, and then we share, we come up with it, and then there's lobbyists that can move things a little forward.
It's not, no, it's not.
So is there any will among the board members to
People,
elevate this issue and say, hey, you know, this is something we've seen a real consequence of?
Yeah.
If you Google it, it's well documented, the effects.
it's sold on the street all around us. I
Yeah.
mean, it's sold on the street all around us, has been for years.
Can you
And
can
all
you
the
inform us? So there was a.
all the surrounding counties.
Can you inform us what was the instance that happened that
Well,
someone
there's
was
a
on that drug?
30-some-year-old male who called you, and he was suicidal, and he had been using this Kratom 7
Uh-huh.
substance. Now, he ended up getting in treatment for substance abuse, but if he had not made that call,
Uh-huh.
we would have had a statistic potentially. And to tell you the truth, there's lots of stuff that's sold that I don't even know about. But when this popped up and I went and Googled it after hearing the story, I was like, it's outrageous that
Yes.
you don't need a script and you can walk in and
Right.
just buy this, and it has these published effects.
Yeah.
To me, it's irresponsible not to say to someone else, hey, this is dangerous.
Yeah.
Is this really what we want in our community? And maybe zoning is one avenue we can tackle, but also, I'm sure this is not just a Scotland County and this one individual.
No, it's not. It's it's in probably every county. It's something that's sold on the street
But
to kind of enhance things.
I guess my take on this is, like we, so like Crampton 7 and, like Spice, K2, all of those, I consider Crampton 7 the same as Spice, K2, fentanyl. To me, they're all in the same boat, right? They're all
They all have the
they're
same
all
taste, yeah.
illicit drugs. They may not be illegal, but they're illicit drugs.
Yeah.
And I would say that we have a known stance for like illicit drugs. And like I know for me as a provider, I'm talking to everybody, you know, that comes in or that I see that you don't need to use illicit drugs. And my stance is also you don't need to vape, because vapes are more dangerous than cigarettes,
That's
right? So you shouldn't even be vaping, because those are not a regulated substance. So you don't know what you're
Yeah.
huffing in through this vape. You could be tearing your lungs to pieces, which you basically are, right? And the kids, some of them don't even know that. So I talk to every kid I see. And do I think that we should be more vocal? Could people be more vocal about telling kids not to vape and not to use these drugs? I do, but I think that comes with another issue that is not like a public health issue, right? That we can tell them not to do it, right? But another thing of the problem is they see the grown-ups going in the same store, getting the same stuff, doing the same thing. So we're trying to advocate, and we keep saying, and we keep telling them. Like in the rooms with them, with the parents, so the parents hear it too. But the same way we say, you know, they had to, you know, the don't do drugs, that big campaign, everything that kids know, that you know. And so I think as a board, we probably can put out like a recommendation. Like we could say, hey, I think the better way to do it is to say, hey, that's our recommendation, and make that recommendation to like the zoning board to let that be a recommendation on the books. And that's part of what they follow. And that's how you have a more meaningful everyday impact, because you can say it and have it posted and do those things. But if we don't take away the access, then you're still gonna get
I
it.
guess it's like the vet saying to us, hey, we're having cases of this encephalitis thing.
Yeah.
All she's doing is alerting us to this, and I guess I'm only advocating that as a health board, we elevate this to the health board in Raleigh and say, hey, we may be one of 90 other voices. I don't know if we are or not.
So I would say that we are, because I can say that. Well, I don't know how Amanda advocates, right, for this health department, but personally, just being a provider that lives here, right, I know I advocate to my North Carolina Medical Board, to my chapter of the American Academy of Pediatrics. Like, I work on their advocacy council, right? I work on their advocacy group. I actually work with their behavioral mental health, which is why a lot of those things are now coming here. Like, because I went up in Tom Tillis's office. Like, I went up and talked with these senators and talked to the representatives about it and told my own personal stories to them. So they do hear us, and it is people like us that are on this board that really are speaking up. And I'll take it to say that sometimes people may not hear it, but it does not mean that it's not being said.
But
I
I mean,
think-
is it too much to ask to get a letter out of this board to the state health board and just say, hey, we have a concern about this substance. Please let us know what may be some effective measures to deal with
It'd be great.
what's being done. I mean,
Because I think if you write it up, we all can agree and we can all go over it
And I
and we
think
will
there's a
sign it.
bigger picture. It's not just that substance. I'd never
Yes.
heard of that drug. But I've driven by the smoke shop. I drive by that spot a lot, and it never crossed my mind that somebody ought to say, is this a good idea to have across the street from the high school? I mean, should the ABC store move over there? You know? But then somebody else is gonna say, we're gonna close a convenience store too. They sell tobacco. They sell vaping products.
Yeah.
But they're a convenience store. They're not a
I think
vape shop. But I think, I would rather see a letter saying we make a recommendation that the location of that vape shop is inappropriate because it's putting it right in front of our children. I mean, come on. But they're already there. They've already gotten, I don't know how that works.
I'd be happy to see that letter come to the Board of Commissioners, and we would get our attorney to look at it and see what's possible to do on that end. I'm just saying, if there's one voice that should be advocating for health, it's right here on these three tables, and I just think it's more authoritative coming from this group. And I know we all do our own private advocacy. I'm not diminishing that. I'm just saying, to say officially, this is what we're seeing and the impact.
Yeah.
Well,
'Cause
I
I
think
read
that's a
So,
good idea.
so now my next question is, the person at the table that has the most experience here is Amanda. So how effective, what is your suggestion, Amanda?
I agree. Start here.
Okay.
Can we also charge you as a board when you go to Raleigh tomorrow, if you have opportunities to discuss this drug or any like it that are just easy sales over the counter legally, on what other counties may be doing, if they're facing similar challenges, and if we can initiate any kind of lobbying from that larger organization you're connected with, that this board is behind that. But I do agree, if we could pull together a letter of recommendation from this board, at least, if nothing else, stating what we know to be an issue.
Well, I can tell you, the county attorney can do a lot more with something from this board than it can do just saying, hey, I've read this and I think this is
Yeah.
a problem. That's kind of the purpose, or one of the roles of this board, so.
Okay.
We're all in
I know,
agreement.
like, right now, and Kathy, she can tell you a little bit more about it, is another growing concern is the flavor in the vapes being enticing to the
Kids.
teenagers. That's one thing that they're working on right now too, so this.
As far as July 1st, they have banned some of the vape
Mhm.
groups.
Yeah.
So
Valentina, when you give a certificate of occupancy to like a smoke shop, you don't approve everything they sell in there, do you?
I don't regulate smoke shops.
No.
Only regulate establishments with food,
Food.
Gotcha. So, yeah, you're not even involved in this.
unless they're doing hot dogs. Then
Yeah. you're so-
Oh, some
You know,
sell
that
hot
might
dogs.
become a thing.
Some do
Some
sell
people
hot
get the
dogs.
munchies.
Yes.
But as an aside, we are expecting the legalization of marijuana to be coming down
It's
the
coming.
road. So, and we think that it's gonna be or somewhat governed through the ABC system. So you could see, when you start talking about stuff like Kratom, and then you start talking about having dispensaries and tax revenue generated and the whole ABC type network for cannabis, it's gonna really change a lot of things based on what we know about the effects of long-term use or maybe in a greater use. So I think there are some real health things that are out there.
Yeah, thank you for bringing it up.
Yeah.
Any other comments?
Make a motion to adjourn.
Second.
We've got a second to adjourn. All right, all in favor, make it known by saying aye.
Aye.
Thank you all. And Amanda, do you know the date for the next meeting? Just mention that.
Next meeting.
It's October.
Sorry you had to sit next to the light.
Let me see what it's
October
on.
Might be the
Can't remember.